I'm glad to introduce Dr. David Treiman today as our speaker. But before, please, just a quick reminder that there will be a code at the end of this talk that you can text to our CME office for CME credit. And for people in the room, please silence your phones. Dr. Treiman is the Newsom Chair of Epileptology and Director of Epilepsy Program and the Clinical Neurophysiology Laboratories at the Barrow Neurological Institute in Phoenix. He's also the Clinical Neurophysiology and Epilepsy Fellowship Program Director and Director of the Laboratory for Translational Epilepsy Research at Barrow. Dr. Treiman is a professor of neuroscience and bioengineering at Arizona State University, a clinical professor of neurology at the University of Arizona College of Medicine, and professor of neurology at Creighton University School of Medicine. As you all know, he's the current editor-in-chief of the widely read journal Epilepsy Research. Dr. Treiman completed his undergraduate degree at the University of California in Berkeley before he went to Stanford University in Palo Alto, California for his medical degree. He then pursued his clinical training in medicine and neurology at Duke University. He joined the Navy Medical Corps briefly before he joined the faculty at UCLA in Los Angeles, where he became professor of neurology. In 1997, David became the chair of neurology at UMDNJ, Robert Wood Johnson School of Medicine in New Jersey for a few years before he returned to the West. His research focuses on treatment of epilepsy, including mechanisms and treatment of status epilepticus. Indeed, a lot of what dictates our current management of status epilepticus has been dictated by the results of Dr. Treiman's studies published in the New England Journal of Medicine, the VA co-op studies. And he's also interested in development of new drugs and novel non-pharmacological interventions for the treatment of epilepsy and the prediction and prevention of epileptogenesis after status epilepticus and after traumatic brain injury. David, welcome to Washington.
Well, thank you very much for that gracious invitation, and thank you for the invitation to speak in this very distinguished series of epilepsy lectures that you have put together. So it's really my pleasure to be here. Let me just start out from the beginning. The only disclosures are that I am on the Speakers Bureau of Synovian and UCB, and other than that, everybody else involved in this lecture has no disclosures. The learning objectives are listed here. We're going to talk about the dynamic character of status, changes at the synaptic level that explain the progressive refractoriness to treatment, and treatment will end up with a treatment protocol, and actually finally end up with some of my thoughts about perhaps future treatments of some of the more difficult to treat aspects of status. This is an accredited CME activity. This is how you claim credit. And let's start out with the lecture. So the caption on this cartoon has one pilot saying to another, "Say, what's a mountain goat doing way up here in a cloud bank?" Ladies and gentlemen, I submit to you that these pilots are about to experience an aeronautical emergency. But what I want to talk about is the most severe epilepsy emergency that we deal with, which is indeed status epilepticus, which is not all that uncommon. 10 relatively recent studies all show similar results with an overall incidence of somewhere between 10 and 60 per 100,000 per year, most commonly in the very young, less than a year old, and in the elderly, which is really quite high. And I'm sure you all know the definition of elderly, which is 10 years older than the oldest person in the room. It's a floating kind of number, and as I get older, it gets higher and higher. Based on the data that were developed in Richmond, Virginia, Bob De Lorenzo and colleagues estimated that there were, at the time they were writing, at least 150,000 cases of status in the US each year, and if you extrapolate that, that means there are more than 3 million cases of status epilepticus in the world. And when we talk a little bit about mortality, you'll see why this is such a devastating number. All of these numbers are really supported by a meta-analysis which was just published last year in the journal IADIT, Epilepsy Research, in which 43 studies were looked at with very similar results in terms of the epidemiology of status, the frequency of status. So this is a very devastating disorder which occurs, unfortunately, all too frequently. And you can see Dale Hesdorfer's curve there that shows the U-shaped curve, which is similar for epilepsy itself, with a very high incidence in the very young and in older patients. So let us define status epilepticus, and we're talking about a situation. Traditionally, we've said, well, status epilepticus is defined as repeated seizures without full recovery between the seizures, or as more or less continuous seizure activity for some specified period of time, which started out with people saying, well, the seizures lasted more than 60 minutes. And then somebody eventually figured out, well, maybe 30. And then maybe 10, and that was the definition we used in the VA study, which you heard mentioned and which I will tell you a little bit about. And about 10 or more years ago, there was a paper that suggested that maybe even 5 minutes duration of seizure activity should be considered status. I'm a little concerned about that definition because we've all seen complex partial seizures that may last 10 or 15 or maybe even 20 minutes documented with EEG changes. So to define status as continuous seizure activity more than 5 minutes is, I think, a little worrisome to me, but I suppose it depends on whether you're talking about convulsive status, convulsive seizure activity or some other kind of seizure activity. In any event, I think rather than getting into an argument about how long seizures should persist before we say that this is status epilepticus, if we think pathophysiologically, then about almost 20 years ago now, I suggested that we might define status in a different way. And that is, if we define status epilepticus as repeated seizures where any effect of one seizure, that is postictal depression, Todd's postictal paralysis, EEG slowing, some neurochemical or neurophysiologic change that we can measure, where any effect from one seizure is still present when another seizure occurs, then that patient is in a continuous state of epilepsy or status epilepticus. And I think that gets us away from these arguments about how long does it have to last, and that really begins to address the whole pathophysiology of status epilepticus if we think of it in that way. And that leads us to the conclusion, the obvious conclusion, that status epilepticus, if it is untreated or inadequately treated so that it does not stop, if it continues, it is a dynamic condition. And thus, if it's not stopped, there is an evolution of behavioral, electrical, neurochemical, and pathological features. There is a progressive decline in treatment responsiveness, and there is a progressive increase in severe consequences of status epilepticus. And that is, I think, an important concept. Status epilepticus is not a static state. It is a dynamic state that the longer it goes, the worse things get. So one example of this kind of dynamic change that we're talking about is a predictable sequence of progressive EEG changes during untreated or sometimes even inadequately treated, at least generalized convulsive status epilepticus. And what happens, and this is a pattern that I and my colleagues first identified and published, I guess now almost 30 years ago. Of course, I was 9 years old at the time, you have to understand that. So what happens is that a patient may start out with discrete electrographic seizures and behavioral seizures concomitantly with the electrographic seizures in the same way that we see a generalized convulsion on the epilepsy monitoring unit when we've been a little over-aggressive and we've taken away drugs a little too fast and the patient has a generalized convulsion. But if status persists, then over time, those discrete seizures begin to merge together to produce a waxing and waning pattern, which eventually becomes continuous, which then begins to be punctuated by periods of relative flattening, which get longer as the ictal discharges get shorter, until finally we're left with periodic epileptiform discharges on a relatively flat background. And this is an example of these patterns. So this is the end of the my arrow is showing good. The end of the clonic phase of a discrete electrographic seizure. You can see this waxing and waning kind of pattern. You can see this fast stuff, slower stuff over here getting faster. Down here is continuous spike wave activity, and this line here is a 16-minute hiatus. This continuous activity goes on and on. This is an example of this kind of continuous spiking punctuated by periods of relative flattening, and this is an example of periodic epileptiform discharges on a relatively flat background. Now, how do we know that this is the sequence of EEG changes during generalized convulsive status? Did we say, well, look, we're going to take a bunch of patients who are in generalized convulsive status and we're not going to treat them and we're going to record their EEG? Of course not. Well, then I thought, well, maybe we could hire medical students and they might let us put them into status and then we'll record the EEG. But medical students, of course, are much too smart for that. Even if we paid them, they weren't going to do that. But law students will do anything for money. So I thought about the law school, but then the dean didn't like that very much. So I thought, well, okay, so the only solution is we need to go to the laboratory. And what we did is that we looked at the EEG in 3 different rat models of status, as shown here. And so what we have is we have 3 different models. We have a rat put into status using canic acid. We have a rat, where's my arrow? There we go. Okay, so the middle pattern is a rat put into status by creating a cobalt lesion over the left motor strip and then inducing status epilepticus by a homocysteine thiolactone injection, and the bottom is the lithium pilocarpine model. And in each case, in each one of the 5 panels, I'm showing you the EEG from the same rat, but then recorded progressively longer, and what you see is that you see the 5 patterns: discrete electrographic seizures, and then merging together, and then continuous and continuous with flat periods and periodic epileptiform discharges. But what is important is to look down at the bottom right-hand panel and recognize that the time to get to this EEG, status epilepticus EEG stage 5, is much longer for the canic acid rat than it was for the cobalt homocysteine and the lithium pilocarpine rat, and this was an observation that we have observed over and over again. So the particular model determines how fast this series of EEG changes goes, and I'm going to show you data in a little bit from Howard Goodkin's laboratory, which actually documents the same phenomenon. Now, it turns out that this pattern of progressive EEG changes during generalized convulsive status has been observed after we initially observed this in the people in these 3 rat models. It's been observed in a number of other models by a number of investigators listed here, and also by others in both human and in human generalized convulsive status and in complex partial status. And this is one of these examples of another model. This is a Soman. That's one of the nerve agents that the bad guys use these days. They're still using it, as we know. Those of you who read the newspapers know that the Russians have been up to no good. But so Soman's another one of these nerve agents, and what you see here is a study by Koplowitz and colleagues where you see the same 5 patterns that I've just described to you in this Soman model, just as an example. What this is actually a recording, the only one that I know about, where all 5 of these patterns have been recorded in the same patient. And the reason I can show you this pattern is because Travis Losey, who was once one of our epilepsy fellows and is now the head of the epilepsy program at Loma Linda University, had a patient who was pretty much an extremist, and her family did not want any kind of heroic intervention. But Dr. Losey recognized that she was indeed starting to have some seizures, and he was concerned that she would end up in status. And he said to the family, well, look, I understand that you don't want to intervene, and that's okay, but would you mind if we recorded the EEG? And it turned out that in this patient, Dr. Losey was able to record all 5 of the patterns in the sequence I've just described to you in this one patient whose family did not want treatment. So this is the one example of a patient untreated where we have all 5 of these patterns that you can see those there, starting with the discrete electrographic seizures and ending up with periodic epileptiform discharges on a flat background, and finally electrocerebral silence. So why do we care? Why do we care about these patterns? And the answer is, well, they help us make the diagnosis of status epilepticus, and they tell us when to treat. If any one of these 5 patterns call for treatment, especially if seen in the context of clinical indications of possible status epilepticus. Now, all of us who read EEGs have been faced with the problem where we see a kind of a spike wave pattern or more commonly a triphasic pattern, some other kind of periodic pattern, and we're scratching our heads and we're saying, well, is this metabolic encephalopathy, is it status, or what have you? So the context in which we see these patterns does count, but of course if you see a sequence of changes like I've described to you, well, that's a pretty indication that it's indeed status epilepticus. So if you see any one of these patterns in a situation where you suspect status epilepticus, this tells you that you should treat. These patterns, and I will show you in a moment, well, in a few minutes, some data that supports this idea. They are markers of the severity of the episode of status, and they predict the ease of treatment and outcome. And in the comatose patient, and that is coma secondary to the brain insult that caused the status, or secondary to the treatment, IV general anesthesia, for instance, they tell us if the patient is still in status and still requires anti-epileptic drugs. So for all of these reasons, I think these patterns are quite valuable to observe, and this is one of the many reasons that continuous video EEG monitoring, especially in the ICU, has become so prevalent just in the last not too many years. All right. What about this question of response to treatment? I made the assertion that the longer status goes, the harder it is to treat, and I will now make the assertion that the later the EEG pattern, the harder it is to treat. And these are data that Nancy Walton and I generated, again, 30 years ago, yeah, that show that if you look here at the number of animals in which all seizures stopped, at animals treated with diazepam, this is 20 milligrams per kilogram, is a huge dose for a rat. All of the animals stopped. If the animals just got to the stage 2 or 3, merging or continuous, well, merging 3 of 6, continuous 1 of 6, and periodic epileptiform discharges 1 of 6, had all seizures stopped. And as you see in the second from left column, of course, the later the EEG stage, the longer status had gone. We still don't know the real answer of is it the duration or the EEG pattern that predicts response to treatment. We do have other data, and these were data generated by Jaideep Kapoor and Bob McDonald when Jaideep was a postdoctoral fellow. And what they show is that if you treat after 10 minutes, the ED50 in this particular situation. The ED50 for diazepam was 4.2 milligrams per kilogram. If they waited until 45 minutes waited for 45 minutes after status had started, the ED50 was 40 milligrams per kilogram. So the later the EEG stage, the more drug it takes to stop status, the harder it is to stop. From the VA data, which was already described, we know that if we look at all of the patients to treat it with any one of the 4 treatments, we know that the mean time from the start of the very first seizure to the time of success was 3.8 hours in those patients who responded to the first drug. And those patients who did not respond to the first drug, the mean time was 9.1 hours. Now you might say, well, gee, what's wrong with you guys? How come it took 3.8 hours to stop status after the beginning, even in the responders? And the answer is because we were very conservative in our estimate of when status started. If Mr. Smith had a couple of seizures at midnight and his wife put him to bed, and at 7 in the morning he didn't wake up and she called the ambulance, we count at midnight as the start of status. So using those kinds of numbers, that's why we end up with this 3.8 hours even for the responders, and of course 9.1 for the failures. So so it turns out the longer things go before you start to treat, the worse things are, the worse the responsiveness. The later the EEG pattern, the harder it is to stop. This is from this VA study. And those patients who exhibited the discrete electrographic seizure pattern had a 75% success rate with the first treatment, about 30% with the second treatment, less than 25% with the third treatment, with the third pattern. And then less than 10% response if the patient exhibited continuous seizure activity punctuated by flat periods or periodic epileptiform discharges at the start of treatment. So these data illustrate the response to treatment based on the pattern that the patient exhibited at the onset of treatment. We still don't know. Is it the duration or is it the EEG pattern? Because these are obviously linked. Well, Jae-Moon Kim, when he was a postdoc in my lab some years ago, did an interesting little study where he used the high-dose pilocarpine model of status in the rat. And he said, well, okay, in this model, the rats proceed through these EEG patterns pretty quickly. And at 10 minutes after the first discrete seizure, about half of them are still exhibiting the discrete seizure pattern on the EEG. But the other half have progressed very rapidly through phase 2 and now are exhibiting the continuous EEG pattern. And look what happened. What happened was he says, well, okay, at 10 minutes, we're going to treat with 5 milligrams per kilogram of diazepam, and we'll see what the response is. And it turned out that 13 of 16 rats that exhibited the discrete electrographic seizure pattern at the time of treatment responded, but only 1 of 16 that exhibited the continuous electrographic seizure pattern responded to the same 5 milligrams per kilogram of diazepam. So in this experiment, it was clearly the EEG pattern that predicted response to treatment, not the duration of status, because 10 minutes was the duration of status in both cases. Much more recently, in fact, just this year, Joshi from Howard Goodkin's laboratory published an interesting paper where the top panel shows the response to treatment at at 3 minutes and then at 1 hour responds to diazepam. And what you see is that you see that the ED50 was 6.5 milligrams when the animals were treated right away at 3 minutes, and there was no response at all at 1 hour. The bottom pattern, the middle pattern exhibits the response to treatment in the canic acid model, and it turned out that the ED50 was 10 milligrams per kilogram at 60 minutes, and then if you go to the bottom, even 3 hours later, the ED50 was only 14 milligrams per kilogram. So what this demonstrated clearly was that the etiology of status, in this case the particular model of status epilepticus used in the rat, made a huge difference in terms of response to treatment. And I'm going to talk a little bit about why that might have been indeed the case. Because what happened was that at 1 hour in the lithium pilocarpine animals, they were showing the continuous or continuous with flat period EEG patterns, whereas the canic acid animals at 1 hour were showing the waxing and waning pattern, at 3 hours the continuous, and then even at 7 hours they'd only gotten to continuous with flat period. So canic acid status, as I've already indicated to you, goes much more slowly than lithium pilocarpine or cobalt homocysteine status. So the question becomes, why does status epilepticus become refractory? And the answer is that it has a lot to do, but not entirely, to do with attenuation of GABA-mediated inhibition in mid to late status. Brooks, Kyle, and Doug Coulter demonstrated some years ago, almost 20 years ago now, there was a rearrangement of the GABA-A receptor subunits, and Jones Davis, working with Bob McDonald, a few years later, hypothesized that there were possible changes in the gamma-2 and alpha-1 GABA-A receptor subunits. But the most important advance really was the recognition by David Naylor and colleagues in Claude Wasterlane's lab and Howard Goodkin and colleagues that there is, as status epilepticus progresses, there's a progressive internalization of GABA-A receptors at the synaptic GABA-A receptors, and there's a progressive externalization of NMDA receptors, as shown here. So the left-hand panels show the GABA-A receptors with lots of them at the synaptic membrane and only a few NMDA receptors. And then after 10 seizures, that's shown in the right-hand panels, you see far fewer GABA-A receptors at the synaptic level and far more NMDA receptors. So this is, of course, a cartoon, but this is based on, this is a summary of the observations that Naylor in slices and Goodkin and colleagues in a cell culture model were able to observe. And it turns out that if we go back to that same Joshi experiment that I just described a few moments ago, it turns out that if you look at the middle column, it turns out that in the lithium pilocarpine animals, that's this, where's my arrow? I can't find it. But anyway, in the top of the top panel of the middle column, it turns out that there's a marked attenuation of surface expression of the GABA receptor gamma-2 subunit, and as I've already indicated to you, a decrease in response to treatment. And whereas in the canic acid animals at 1 hour and 3 hours, there was really very little change in the gamma-2 receptors, as shown here. So we've begun to understand that there is this progressive change in GABA A receptors at the synaptic membrane as internalization and externalization of NMDA receptors. And we also have now recognized that this is related to the EEG pattern because it happened because in the lithium pilocarpine model, where the EEG patterns progress rapidly, we see that by the time the animals become refractory, that there's an attenuation of these gamma-2 receptors, whereas in the canic acid model, where which goes much more slowly, there is really no change at even 3 hours later. And in fact, we've begun to understand a little more about the pathophysiology of this electroclinical evolution of status. I've already described the Naylor and Goodkin observations. Teronuma and colleagues demonstrated deficits in phosphorylation of the GABA-A receptors. In a more recent study, Goodkin and colleagues demonstrated that as I've already shown you, that the GABA beta 2, I haven't shown you that, but the GABA beta 2 and 3 and the gamma 2 subunits are reduced, whereas the delta subunits, which are in the extrasynaptic GABA receptors and are responsible for tonic inhibition, are not reduced. Subsequent study showed that status, and this is out of Jaideep Kapoor's lab, showed that status can be terminated by AMPA antagonism. Naylor finally got around to publishing his earlier observation that there is an externalization of NMDA receptors in 2013, and then recently I showed you some data, some earlier data, and recently Sun and Goodkin demonstrated that we're able to again demonstrate that modification of the synaptic GABA-mediated inhibition, and that this is a pervasive and early phenomenon. Let's talk a minute about the role of neuroactive steroids for the treatment of status. And the reason that we need to talk about neuroactive steroids is because as we've already been talking about, there is a progressive failure of benzodiazepines because of these changes at the synaptic level, changes in the GABA receptors. But it turns out that neuroactive steroids actually act at the delta receptor in the extrasynaptic GABA receptors, at the delta component, and these are not attenuated during the course of status. And these are responsible for tonic inhibition as opposed to phasic inhibition, which is what the synaptic GABA receptors do. And therefore, these are not desensitized during the course of status epilepticus, and this led to the idea that a neuroactive steroid might in fact be effective in status, and these data from Mike Rogowski and colleagues demonstrate in fact that very phenomenon. That is that if you compare diazepam and allopregnanolone in a pediatric rat status model at 30 minutes, that's in the right here, okay, that's in this set of columns, you see that there's no difference between the diazepam and the allopregnanolone. But if you, at either at 30 minutes or at 70 minutes in terms of outcome. But if you wait until 40 minutes before you treat, then it turns out that the neurosteroid, the allopregnanolone, works, whereas the diazepam does not work nearly as well. So that if you're treating if you treat at early status, diazepam works as well as the neurosteroid. If you treat at late status, then it turns out that diazepam doesn't work very well for the reasons we've just been talking about, but the allopregnanolone and presumably other neurosteroids will work. Now, many of you probably know about the SAGE trial that unfortunately turned out to not be a positive trial, which this was a look at allopregnanolone in super-refractory status epilepticus, defined as failure of a intravenous general anesthetic for more than 24 hours. And it turned out that there was no difference between the placebo-treated and the allopregnanolone-treated patients. I think that this had to do with the study design more than the failure of the drug. That's my perception, and I think I see at least one nod in the audience. I think that I would have designed that study differently, and I think there's still a role for neurosteroids in the treatment of refractory, and certainly in treatment of super-refractory status epilepticus. Okay, so I want to turn to what we know now about treatment of status epilepticus in 2018. And I begin with a quotation from Bertrand Russell, whom some of you may know, was a very well-known, very good philosopher in the UK, who, among other things, wrote, "The opinions that are held with passion are always those for which no good ground exists." Now, the reality is he was talking about religion. Okay, we'll leave that aside. But I like this quote because when I first got into this business and when I started, actually maybe didn't first get in, but I began to think after a while that I didn't really know how to treat status epilepticus on the basis of any real data. I mean, if somebody had asked me, how do I treat status, I would have given them some kind of an answer. And if somebody said, well, why do you do it that way? I would have said, well, that's because my chief resident told me to do it that way. You know, that's kind of how a lot of us learn. But the problem was that the chief resident did it that way because his chief resident or her chief resident did it that way. There were no data. So I thought, well, let's solve this problem. I thought that, in fact, the opinions that were held with passion regarding treatment of status were really not based on a good ground. So I thought, let's organize a study that will really settle this question. So what I did was I put together a study comparing the favorite treatment of a substantial number of American neurologists. So each of these 4 treatments I'm showing you, phenytoin alone, diazepam followed by phenytoin, phenobarbital alone, and lorazepam alone at the time that I first wrote this study, which was in 1985. Again, we're going back. I was 3 years old then. No, 6 years old, something like that. In any event, I thought we should compare those treatments. We stratified the patients into those who exhibited overt and those who exhibited subtle generalized convulsive status epilepticus, and we determined treatment by the absence of all clinical, but most importantly, all electrical evidence of seizure activity during a time period from 20 to 60 minutes after the start of infusion. And some people came along afterwards, especially when they saw the results and their favorite drug hadn't won, and they said, oh, you should have counted from the end of infusion. No. This is not kindergarten. We don't have to give a trophy to every kid who plays the game. We have to figure out what's the best drug. And the best drug is the drug that stops status from the start of infusion, as soon as we can start treatment. So that's how we did it. But I thought that confirming success with EEG was very important, and there was a committee of 3 of us who did not know what the patient had received. We were completely blind as to treatment, and we determined whether we agreed or didn't agree with the investigator's determination of whether or not status is stopped and exactly when status stopped. We ended up enrolling 581 patients in this largely VA study with some affiliated university hospitals over a 5-year period. It takes a long time to collect status patients. 516 were evaluable, meaning they were actually in status at the time we started treatment. The drugs were packaged in treatment kits so that we were able to give a second and third treatment and maintain the blind. The EEG was started as soon as possible, but we never delayed treatment in order to get an EEG started. And as I've already told you, we did a central review of all the cases. This was largely the population was largely male and largely older patients because it was largely a VA study with other demographics shown here. And the primary outcome is shown here. In this older population, lorazepam was successful as a first treatment, that is complete cessation of all EEG activity indicative of status and of clinical activity in 65%. Phenobarbital 58%, diazepam followed by phenytoin 56%, and phenytoin alone about 44%. The overall chi-square analysis was statistically significant, allowing us to do pairwise comparisons, and in the pairwise comparisons, lorazepam was more often effective than was phenytoin. The other pairwise comparisons were not statistically significant. This is in the overt group. These are patients where they come in and they're flopping around and you can tell that they're in status. In the subtle patients, which were defined operationally as patients where we needed an EEG to make sure that they were in status, in those patients, 24% of the phenobarbital treated patients, 18% of the lorazepam treated patients, and about 8% of the patients treated with phenytoin with or without diazepam responded to the initial treatment. And this should be no surprise now that we understand that patients don't respond very well to diazepam in late status, and we also understand from the overt group that phenytoin is not a terribly good anti-status drug. Overall, the chi-square analysis wasn't quite statistically significant, so we really couldn't do pairwise comparisons. And I think the reason for this is that we only had about about one-third as many patients in the subtle group as in the overt group. And that's good, considering the outcome in the differences between overt and subtle outcome, which are indeed shown here. In the overt group, about half had their status stopped and had improved sufficiently to be discharged from the hospital. A little less than a quarter were still in the hospital, and a little more than a quarter had died. So this is a high mortality. But in the subtle group, it's a disaster. Less than 10% had improved sufficiently to be discharged from the hospital at 30 days. A little more than a quarter were still in the hospital, and 2/3 of these patients had died. Now, if I'm a hospital administrator and I see these data, I might be inclined to say, well, hey, Treiman, what are you doing? Why are you bothering with these subtle patients? Look, only 10%, less than 10% get out of the hospital. You know, this is a waste of money. Ladies and gentlemen, if I'm in the 10%, please treat me. We do succeed in some patients, and my bias is therefore we should be trying in everybody. I want to talk about several other important studies. This was a study organized by Dan Lowenstein, and Brian Aldrich ended up being the first author. And what these people did at UCSF was to look at pre-hospital treatment in patients in generalized convulsive status, and they took advantage of the fact that at the time they started the study, right at the end of the last century, about 1998 or thereabouts, the standard of practice among paramedics was some of them gave benzos before the patient got to the hospital, some did not. So they could ethically randomize patients. So they randomized the patients to placebo, to diazepam, or to lorazepam. It turned out that the benzos were, of course, better than the placebo in stopping status. But the most important and interesting observation was the one that's on the bottom bullet point, where it turned out that the patients with cardiorespiratory complications were more than twice as frequent in the placebo treated patients than in the benzodiazepine treated patients. Now, everybody had argued, oh, we don't want to let the paramedics give benzos because they're going to make them stop breathing. But it turns out, no. Actually, in fact, that what happens is that the treating the patient and stopping status was much more beneficial to the patient in terms of cardiorespiratory response as well as protecting the brain than not treating the patient. So that I thought was a very important observation. A study published more recently by Rob Silverglate and colleagues was a study organized to be a non-inferiority trial of IM midazolam compared with IV lorazepam, and it turned out, to everybody's surprise, I think, that IM midazolam was actually superior to IV lorazepam by the criteria listed in the outcome set below: status stopped by hospital arrival, hospitalization, or ICU admission. All of these things were statistically significantly better in favor of midazolam than lorazepam. And the thought is that the time, even though it took only 4 or 5 minutes to get an IV started, that difference, that time difference, probably explained why IM midazolam actually worked better than IV lorazepam. This is a study that Chamberlain and colleagues did in kids, and the results of the summary of this whole set of data is that in almost 300 kids between 3 months and 18 years of age, there was no statistically significant difference in efficacy of between lorazepam and diazepam. So either drug would work. Actually, lorazepam ended up causing more sedation than did diazepam. But that was also an important study. So what do we do, however, if benzodiazepines fail? And we do have 2 older drugs with IV formulations, phenobarbital and phenytoin, and we have 4 new or relatively new drugs with IV preparations: valproate, levetiracetam, lacosamide, and brevitiracetam. These are all available for use if benzodiazepines fail, and the 3 drugs that I have asterisks after phenytoin and valproate and levetiracetam are now being compared as second treatment in an NIH-funded study, established status epilepticus treatment trial. Or actually, it's now not in its first year, and it's in the 3rd year of enrollment. I forgot to make that change. All right. Now, why was that study organized? Well, it was organized because it turned out in the VA study that only 7% of the patients responded to the second drug. 55% was the overall response to the first drug. Only 7% more responded to the second drug, even fewer to the third drug. And finally, it took intravenous general anesthesia to get a response. So clearly, there was a need to identify the best second drug. Meta-analysis didn't provide the answer. This is a study by Simon Charvon and Yassiri, his fellow at the time. And the outcome looks better than the VA study in this meta-analysis of 27 different studies. But none of these drugs clearly have there's no clear difference among these possible second drugs. So it became important to, in fact, in a proper way, identify in a controlled trial, identify the best second drug. And of course, the reason for that is because, as Hugo Munch said, the best way to improve the outcome of a therapeutic trial is to leave out the controls. Okay? So a properly controlled, randomized, blinded study is the only way to go. All right? Because there are many problems with the status epilepticus clinical studies. Few of these have been randomized controlled trials, and even in the randomized controlled trials, randomization and blinding are not specified or have been subject to bias. The definition of type of status and the stage of status has been almost non-existent or variable. Precise operational definitions have been absent. Doses and rates of administration variable. Study populations not well defined, and no attempt to stratify for severity. So the ESET study was organized comparing phosphonatoin, valproate, and levetiracetam, and now in its with the doses and administration rates shown here, and now in its third year, it turns out that recruitment in adults was halted in November 2017. I can't give you details, but except to say that it looked that one would assume that that was because there was either a clear answer or that there was or it was futile to continue because there were no clear differences. There is ongoing recruitment in children, so stay tuned. We still need to know what the final answers are as far as the ESET study go. But in the meantime, just to try to finish this up so that we can stay more or less on time, when we look at, again with Chauvrone with one of his other postdocs, when he looked at anesthetic therapy for refractory status epilepticus, it turned out that looking at a large number of studies, there was no real difference between thiopental or pentobarbital or midazolam or propofol. The outcome in these patients with refractory status epilepticus was pretty terrible, as you see here, with lots of bad outcomes, and recovery to baseline only about 1/3 of the patients. So what does constitute the best treatment, the best practice in the management of status in 2018? And the answer is that we can talk about general principles and then a specific protocol. So obviously do the emergency stuff, establish the ABCs, try to stop the status as soon as possible, monitor patients with EEG, search for and correct etiology. We know that prolonged seizure activity causes neuronal damage independent of the effects of ongoing convulsions, so EEG monitoring is essential to verify successful treatment if you can't tell by looking at the patient. Now, if the patient wakes up and immediately starts quoting Shakespeare to you or tells you what the latest score of some of their favorite college football team or whatever the case may be, you don't need an EEG to tell you done good. You know that. But if the patient is still in coma, you need an EEG to verify that. We know that the longer duration, the later the EEG stage, the more subtle the motor manifestations, the harder status is to stop. And a predetermined treatment protocol is more effective than random choice of drug and dose. So what do I suggest? Well, I would, in 2018, still use lorazepam, 0.1 milligram per kilogram by slow IV push as my initial drug. I would use phosphonatoin until we get better answers or better data. I would use phosphonatoin as the second drug. If status still persists, I would start arranging for intravenous general anesthesia and give either valproate, and probably give valproate. And if general anesthesia is necessary, I would use pentobarb or midazolam or propofol. My favorite is pentobarbital because I'm kind of a dinosaur, but people who are more experienced have grown up using midazolam or propofol. That's equally good because there are no good data that tell us one is better than the other. I would adjust, once I've got status stopped, then the patient's going to be in coma, but now I would adjust phenytoin to 30 micrograms per ml, load the patient up with phenobarbital to achieve a concentration of 100 to 150 micrograms per ml. Huge dose, something you'd never use in chronic seizure management, but these are comatose patients anyway. Alternatively, you could use IV levetiracetam or lacosamide or valproate. Maintain these drugs at these high concentrations as pentobarb is slowed. Slow the infusion periodically, anywhere from 24 to 72 hours. If you treat the patient on Friday night, lighten them up on Monday morning. If you treat them on Saturday night, lighten them up on Monday morning. Why can I say that? Because we don't have any data that tell us otherwise. And what you want is you want a lot of people around as you're lightening them up in case they go back into status. But don't give up. Patients have recovered consciousness after more than 2 months in coma and gone back to a useful existence, and there are the papers reporting that. A couple of them are shown there. All right. As the frog illustrates aptly, as the stork is trying to eat the frog, don't ever give up on these patients. Now, last 3 slides. There are a lot of questions. There are some management questions that affect outcome and complication rates. We don't know how far EEG should be suppressed. My own bias is that we should flatline the EEG. Some people go to burst suppression. In my experience, a lot of times people are looking at what I call status epilepticus stage 4, and they're saying, oh, that's good enough. I think the patient is still in status. How long should we wait before lightening up? We don't know. At least 24 hours. We don't know how long. We don't know what's optimal. How many times should you suppress the patient before giving up? I wouldn't give up. That's my opinion. All right. Because you have to remember that any discussion of the adverse reactions of status epilepticus treatment has to be balanced against the results of no treatment. And in status, the adverse reaction of inadequate treatment is increased morbidity and mortality. So therefore, I would be aggressive in the treatment of patients with status. There are some questions that we have to address in the laboratory related to the pathophysiology of status. What seizure mechanisms, seizure termination mechanisms break down so that seizures continue, so that status epilepticus continues? How do the EEG patterns in status relate to the underlying pathophysiology? I gave you some data. We're only beginning to scratch the surface on that question. What is the mechanism of conversion from overt to subtle to absent motor activity as status progresses? We don't know. What is fundamentally different about the underlying pathophysiology associated with status epilepticus EEG changes 4 and 5 compared with the first 3 stages? And we have some animal data that suggests that that's really a different pattern. So there are a lot of questions. Anybody looking for a project in the laboratory, there are lots and lots of questions that can be addressed. All right, last slide. So what are possible future developments in terms of potential treatment strategies for refractory status and super-refractory status? Well, we've already talked a little bit about the use of neurosteroids, or maybe, in fact, using drugs that increase synaptic GABA to interact with these extrasynaptic sites which don't get internalized. We could think about drugs that might block the internalization of GABA A receptors at the synaptic level, or that might block the externalization of NMDA receptors at the synaptic level. That's early in status. If we look at later status, we might think about a way to reverse this GABA A receptor internalization, or the GABA or the NMDA receptor externalization, and we might also consider trying to find drugs that are NMDA and AMPA receptor antagonists that might in fact block the effect of those excitatory transmitters. So those are some future possibilities, only a few of which are even beginning to be looked at right now, the neurosteroids, et cetera. But these are some ideas that we might think about, and if we could find drugs that might be effective by any one of these mechanisms, it might have an impact, especially on refractory status and super-refractory status. And on that note, thank you very much for your attention. Thank you for hanging in there. Thanks.
Thank you so much. We have a few questions, and then we'll ask if anybody else in the room has some questions. Regarding the definition of status, which you offered in Elaine Wiley's book, that any aftergoing effects of seizure, if they persist until the onset of the other seizure, then that's status. So there is a hypothetical scenario. Somebody has one generalized tonic-clonic seizure every 3 days, but they continue with some TODS paresis, until the following one. This may be considered focal status because the TODS paresis persists, but would you treat it as focal status although the individual seizures are generalized? It's just like more semantics probably than pathophysiology or clinical epileptology.
Okay, well, I mean, I think that's an interesting question, and the answer is that I think I would treat it as focal status not as generalized convulsive status epilepticus. And the important point to be made here is that I think focal status needs to be treated aggressively, but not with sedating drugs. That's the important point, is that I would never take a patient who's lying there and maybe just doing this, twitching, they've got some twitches of their fingers or what have you. I would never take such a patient and make them comatose. Not a good thing. But on the other hand, I'd be as aggressive as I could possibly figure out how to be in order to get that focal status stopped. And I might even, under some circumstances, it would depend a lot on where that focal status, that focus is. There have been a few case reports of surgical treatment, surgical removal of that focus. And it really, as I said, it depends entirely on whether it's a part of the brain, whether the harm you do by doing the surgery would be greater than the harm of the ongoing seizure activity. But no, I wouldn't make the patient comatose.
Here's a question from West Virginia, Dr. Taimur Khan. He says, how aggressive one should treat non-convulsive status in view of the difference of it, if it's in view of the hypothetical difference of its pathophysiology from that of convulsive status, which is related to what you just said.
Well, okay, but except that there's a distinction between, between focal status, what we used to call simple partial status epilepticus, where the patient remains entirely awake, where I don't think you should make the patient comatose, and the patient who is in complex partial status, where there is an impairment of an alteration of consciousness. Now, I think you have to further define non-convulsive status, and part of the problem is that there's been a lot of use of that term non-convulsive status, sometimes to mean spike wave stupor, sometimes to mean complex partial status, and sometimes, in fact, to mean this late, very sick episodes of status and profound encephalopathy, and those are different. But if you're talking about spike wave stupor, I would be. Usually those are pretty responsive to treatment. I'd be moderately aggressive, but I'd be careful. I'd try to titrate. If you're talking about complex partial status, I think that needs to be stopped, because if you have prolonged complex partial status, what we used to call, to use the old terminology, then I think those patients that status needs to be stopped, because you're going to end up frying the hippocampus, probably, if you let the status go. So I would be pretty aggressive. It's a matter of titration. You never want to cause more harm than you're helping. So it's a matter of titrating, but I wouldn't give up. There are a lot of things that one can try. I didn't talk about things like ketamine and other drugs that people are beginning to use, but there are a lot of different possibilities that one could consider.
A couple of other questions. One is, clonazepam is given intravenously in many European countries, and the results are impressive because of its long-acting, longer half-life, and because of its fast penetration to the central nervous system. What are I know in the United States we don't use it intravenously, but what are your views on that?
I suspect that if there were a direct head-to-head comparison of diazepam, lorazepam, clonazepam, we wouldn't see a lot of difference in terms of the acute effect. Now, you mentioned this longer half-life, but the reality is that lorazepam, which many of us would use preferentially over diazepam, is used not because it has a longer elimination half-life, because in fact its elimination half-life is about half of that of diazepam, but rather because it has a longer period of retention in the brain. And we have some old rat data on that. But that's the reason, one reason for using lorazepam, because you don't, it used to be when we only had diazepam. You treat the patient, you get the status stopped, you sit down and you write your note, you're walking out of the ICU 20 minutes after you've gotten status stopped, and the nurse is running after you saying, "Doctor, doctor, the patient's having seizures again." And that's because Diazepam is so fat soluble that it goes into the brain very readily, but then it comes right back out and redistributes to other body fat. So that's one reason that, and whereas lorazepam, which is actually less fat soluble, goes in a little more slowly, but then it stays longer. So my answer regarding clonazepam is I don't think anybody in the United States is going to want to invest the time and energy and money to do a direct head-to-head comparison, because we already have some pretty good benzodiazepines that we do use.
Right. Thank you. And there was a recent paper in the Annals of Neurology published by Atif Hussain and colleagues from Duke finding lacosamide to be non-inferior to fosphenytoin in status. What is your experience with lacosamide in status?
Limited. I mean, certainly we use lacosamide in as one of the drugs that we're loading the patients up with once we've tried to acutely treat the status. I have very limited experience. Actually, I have really no acute experience with acute treatment of status with lacosamide. But my response would be, if it's non-inferior to fosphenytoin, but fosphenytoin was clearly the inferior drug among the four that we studied in the VA study, why would they have compared it to fosphenytoin? Why didn't they compare it to, I don't know, I mean, to something else rather than fosphenytoin? But you're talking about as a second treatment.
Well, the design of the study is probably such that you cannot investigate a drug against the initial benzodiazepine.
That's true. That's true.
But you can compare it with the second line, which is the fosphenytoin.
Yeah. Well, I mean, I think it's a perfectly reasonable idea. As a second drug, it's a perfectly reasonable idea. It was not included in the ESET study because at the time the study was submitted to NIH, there were not sufficient data to justify including lacosamide in the comparison of these between valproate, fosphenytoin, and levetiracetam as the second drug.
My question you partly already answered. I just wanted to know your experience with lacosamide, because the dose that you listed was 800 milligram. I tried it once and I put the patient in PR prolongation. So I just wanted to know your experience, because the doses of lacosamide that you listed and even levetiracetam were like higher than what we're used to. So. Okay,
well, as I've said, I do not have a lot of experience with lacosamide, but we have used doses that high without getting the patient into trouble. I mean, that's what I can say, but I cannot give you a good set of data that really supports that idea.
Yeah, I understand.
Okay.
Let me just say one quick thing for those who are still watching and they would like the code for the CME. It's 11701.
Oh, there we go.
Oh, here you go.
Yeah,
That's
yeah.
the
Okay,
slide.
I'm sorry, I forgot to go to the next
All right.
slide. But there you go. Yeah, 11701. Yeah.
Thank you so much.
Thank you.